And good evening. It is Sunday night here at the Ohio Academy of Family Physicians. And you know what that means? That means it's bite-sized learning. I am your host and moderator, Dr. Mike Sevilla. We have a great topic here tonight, talking about physician well-being, physician burnout. Some people don't like to use that term. I understand that. But we have a great topic coming up with the Ohio Physicians Health Program. But before that, I just want to remind everybody, we have a lot of great education here at the Ohio Academy of Family Physicians that you can find at OhioAFP.org, especially when it comes to maintaining your board certification. We talked recently about the EasyPI program for performance improvement. Also coming up in the next few weeks, we have great programming when it comes to KSAs and also other CME program. You can get all the information there at OhioAFP.org. Excuse me. And so before I introduce our speaker tonight, I just want to let you know that this program does have financial support provided by the American Academy of Family Physicians Foundation to the Family Medicine Philanthropic Consortium, and is funded by members like you of the OAFP. Help programs like this continue to support family medicine by giving to the AAFP Foundation. When you go there, select chapter grants when making your gift online. So as I discussed at the top, we do have a speaker from the Ohio Physicians Health Program. I just want to let you know that in August 2021, OhioPHP, in collaboration with 13 Ohio's professional licensing boards, deployed a comprehensive survey to all of Ohio's professional healthcare professionals about the impact of COVID-19 and their mental health well-being. Over 13,000 professionals responded to the survey. And our speaker tonight is Dr. Richard Whitney, Medical Director of OhioPHP. Previously, Dr. Whitney practiced addiction medicine at Shepherd Hill, the Behavioral Health Department of Licking Memorial Hospital in Newark, Ohio, and served as Medical Director of Addiction Services from 2001 until 2018. He is a frequent course instructor for the American Society of Addiction Medicine, as well as a lecturer for a variety of professional and community organizations. So, welcome, Dr. Whitney. Thank you so much for taking the time for us here this evening.
Thank you, Dr. Sevilla, and I'm very happy to be here. Hello to everyone, whether you're watching this live or recorded. I think we've got some interesting information for your perusal tonight. As Dr. Sevilla mentioned, we're going to talk about the Ohio PHP, about our COVID-19 survey, the results of that survey, and some other, I think, very valuable and potentially very impactful new programs that we're offering at the Ohio Physicians Health Program. We titled this tonight, When Our Healthcare Professional Needs Help. This is primarily geared toward physicians and other licensees of the State Medical Board of Ohio, although we do offer our services for a number of other board licensees. I did join 2021 last year as medical director. Last year there was 8 of us in the organization. Now there's 21. We're headed toward 42. We're growing quite rapidly, and very much enjoying my tenure as medical director. I was medical director at State Medical Board of Ohio approved program at Shepherd Hill for 17 years, and I'm glad to be here tonight. Now, a little bit about Ohio PHP. We are a nonprofit organization providing confidential, you'll hear my favorite C word a number of times tonight, confidential services to the fullest extent allowed by law. We provide a compassionate and supportive and safe environment for licensed healthcare professionals to receive confidential services to improve their health and well-being. We believe that by providing confidential services to healthcare professionals, we can help facilitate and encourage individuals to seek treatment and improve their health and well-being. So tonight we're going to talk some about substance use disorders, and most specifically substance use disorders in healthcare professionals. We're going to talk about the State Medical Board of Ohio One Bite program, and then other services that we have at Ohio PHP and any Q&A that might come up after my formal presentation. So let's talk a bit about substance use disorders, and may I strongly encourage, beg, plead, and grovel with all of you to take the terms substance abuse, alcohol abuse, and drug abuse and throw it out the window. These were replaced in 2013 with a non-stigmatizing term, diagnostic term, substance use disorder. We can also say alcohol use disorder, opioid use disorder, stimulant use disorder, but please, substance abuse, alcohol abuse, and drug abuse are no longer acceptable and still quite stigmatizing terms. They remind people of child abuse and spousal abuse. Now, substance use disorders are a very frequently occurring disorder in this country. A random selection of your patients would reveal that at least 1 in 10 have either a diagnosed or an undiagnosed substance use disorder, an adult population, of course. Estimates of about 23 million fellow Americans suffering from substance use disorders in this country. And one of the real shames of this disorder is only about 10% of Americans who are diagnosed with a substance use disorder ever receive treatment. If this is true for diabetes or cancer or asthma or COPD or hypertension, there'd be a national uprising to make sure that everyone was screened for it. So may I strongly urge and implore you to ask questions and see if we do have an underlying undiagnosed substance use disorder in any of your family practice patients. Briefly, this is a chronic disease. It is not an acute illness. There are underlying brain changes and neural circuitry that persist beyond withdrawal management, formerly called detoxification, especially in individuals with severe conditions. We used to think in the old days that once an individual was detoxified, they were no longer addicted. We know now that underlying circuitry abnormalities in the brain persist beyond detoxification. Number two, and very importantly, this is a treatable condition. With good quality professional treatment, a substance use disorder can have the same remission rate, approaching about 50%, very similar to other chronic illnesses such as asthma, COPD, chronic congestive heart failure, diabetes, and so forth. Third, an important point, this is a progressive illness. Left untreated, this condition always proceeds in a downward direction, and over time, physical, emotional, and social changes are cumulative and progress as the substance use continues, whether it's alcohol, stimulants, opioids, or whatever. And number four, very importantly, we can never forget this is a potentially fatal illness. That continued use of mood-altering drugs can cause premature death through overdoses, organic complications involving vital organs, and by contributing to suicides, homicides, motor vehicle accidents, and other traumatic events, significantly shorten the average individual's life who has a diagnosed or an undiagnosed and untreated substance use disorder. In general, two primary areas of maladaptive functioning. One would be physical, including tolerance and withdrawal, which I'll talk about shortly, cravings, which is a new diagnostic parameter included in the Diagnostic and Statistical Manual version 5 that came out in 2013, as well as pathological organ changes. Under brain or cognitive functioning, we have distortions of thinking, irrational beliefs, pathological defense mechanisms, primarily including denial, and a combination of all these lead to very unhealthy behaviors. Briefly summarizing the 11 diagnostic criteria that, if fulfilled, can make a diagnosis of a substance use disorder. These are categorized generally under number one, which is impaired control or loss of control over mood-altering substances. The substance is taken in larger amounts or over a longer period of time than is intended. Two, there is a persistent desire or unsuccessful efforts to cut down or control the substance use. Third, a great deal of time is spent in activities obtaining, using, experiencing the effects of, and recovering from the effects of mood-altering drugs. And fourth, craving or a strong urge or desire to use mood-altering substances, an important diagnostic term. The next major category of the symptoms and diagnostic criteria for a substance use disorder is social impairment. Number five being recurrent substance use resulting in a failure to fulfill major role obligations at work, school, or home. People are showing up late to work, not coming to work hungover, coming to work in the middle of the day, missing school, home activities, and so forth because of excessive use of mood-altering substances. 6 is a continuation of substance use despite having persistent or recurrent social or interpersonal problems, which are caused or exacerbated or worsened by the effects of mood altering substances. In other words, are continuing issues with mood altering chemical use, alcohol, opioids, stimulants, benzodiazepines, whatever. And despite awareness of this, continued problems, people are unable to stop and stay stopped, or unable to cut down and stay cut down. And the seventh category, also under social impairment, are that individuals give up important social, occupational, or recreational activities because of recurrent substance use. They no longer attend their kids' baseball games. They make excuses to absent themselves from family activities, from work activities, or recreational activities because of the need for continued use of mood-altering substances or recovering from the effects. The fourth major category under diagnostic criteria is risky use. First being recurrent substance use in situations in which it is physically hazardous. This is most commonly driving a motor vehicle under the influence of mood-altering substances, but it could also be, I think it's a good idea after polishing off a fifth of Jack Daniels to get up on a ladder and try to clean out my gutters, leading to significant accidents, of course. And number 9 is substance use which is continued despite the individual knowing of having persistent or recurrent physical and or psychological problems caused or exacerbated by the substance use. In other words, many times they're aware of the physical and psychological problems caused by persistent mood-altering chemical use, but these individuals, until they're treated appropriately, are unable to cut down and stay cut down, or quit and stay quit. The final category are pharmacological criteria. The first being tolerance, which is an ever-increasing need for markedly increased amounts of the mood-altering substance in order to achieve intoxication or the desired effect. And the desired effect is most often intoxication, mood alteration. And B, or a diminished effect with continued use of the same amount of the substance. This could be prescription opiates. This could be alcohol. In other words, if the amount ingested is for some reason kept level, tolerance would yield a reduced mood-altering effect and reduced intoxication over time because of inborn differences in metabolism, and usually in the liver, and also affecting the brain. And the final pharmacological criteria is withdrawal or an abstinence syndrome. The first is a characteristic withdrawal syndrome, and most of you probably have seen someone in alcohol withdrawal. You might have also seen people in opioid withdrawal, but there is a characteristic abstinence syndrome, withdrawal syndrome, after physical dependence takes hold. And finally, the substance or a closely related substance is taken to relieve or avoid withdrawal symptoms. In other words, someone who is dependent upon alcohol can feel so bad in alcohol withdrawal that they'll want to drink to stop the withdrawals, or allowing us to use benzodiazepines, which act very similarly to alcohol in the brain, to ameliorate the effects of alcohol withdrawal syndrome. Now, these are the 11 criteria that, if you can keep written down nearby so you can refer to them, will help you make a diagnosis in an undiagnosed patient with a substance use disorder. All it takes is 2 to diagnose a mild substance use disorder. Moderate substance use disorder takes 4 or 5 criteria, and severe 6+ criteria. So anybody who has 2 or more criteria should be referred to an individual capable of doing a more in-depth diagnostic evaluation to determine the presence of a more severe substance use disorder. All it takes is 2. Now, what makes it more likely for a physician, a healthcare practitioner, or an average individual to have a likelihood of developing addictive disease or a substance use disorder? First and most important is a genetic predisposition, so carefully pick your parents. For the presence of a parent, grandparent, sibling, or other first-degree relatives significantly increases the likelihood of inheriting the genetic constellation coding for an abnormally intense response to mood-altering chemicals. Second is early exposure to alcohol and drugs. And most of us, unfortunately, and our society will have to agree that our children are beginning mood-altering substances at a very young age, 13, 14, even before high school and middle school. Alcohol, marijuana, and tobacco being the three, if you would, gateway drugs that introduce mood-altering substances to the as yet unmyelinated prefrontal cortex, leading to a higher likelihood of triggering this individual to develop a lifetime substance use disorder. Third factor increasing the likelihood of addiction is self-treatment for another mental health disorder. In other words, I have severe depression, so I think I might use a stimulant. I have severe anxiety, so I think I might drink or try to seek out Xanax off the street, leading to triggering an underlying substance use disorder in individuals who are prone to developing it. Fourth is a traumatic life event. A substantially high number of women diagnosed with a substance use disorder have been sexually molested or abused or assaulted in their lifetime. But other traumatic life events, such as exposure to war, exposure to mass casualty situations, can increase the likelihood of developing an abnormal response to mood-altering chemicals. And fifth, of course, is combinations of the above. Now, an interesting slide, which was reproduced, the first one is 1991 and 92, and then reproduced 10 years later, from the National Institute of Alcohol Abuse and Alcoholism, indicate on the left side of the graph, with or without a family history, early exposure, usually meaning before age 16, to mood-altering chemicals, in this case alcohol, dramatically increases the likelihood of a diagnosis of an alcohol use disorder, used to be called alcohol dependence. This was reproduced, as you can see on the section of the slide on the right, with substantially increased likelihood of developing a lifetime alcohol use disorder with early exposure before the age of 16 to the immature developing unmyelinated brain. Now, when we take an individual diagnosed with a substance use disorder, certainly moderate to severe, but also even mild, and I should indicate that all it takes is an alcohol use disorder or other substance use disorder, mild, two criteria to make a positive diagnosis in a physician under the Healthcare Practice Act of Ohio. When we put these individuals into treatment, what exactly does treatment consist of? Well, number one is telling these individuals that they must remain abstinent from all mood-altering chemicals. It is not safe for somebody in recovery from an alcohol use disorder to take benzodiazepines or to take opioids. Similarly, an individual in recovery from an opiate use disorder must be abstinent from alcohol, marijuana, sleeping pills, Z-drugs, benzodiazepines, and anything that requires a DEA number. Second is treatment as recommended by the ASAM criteria. ASAM, of course, is the American Society of Addiction Medicine, publishes a book called the ASAM criteria, used to be called the Patient Placement Criteria. This is the Bible, if you would, for diagnosis and recommendations for the appropriate level and duration and intensity of treatment for an individual with a substance use disorder, used by treatment facilities, addiction professionals, and insurance companies around the country. The third best treatment practice is strong consideration of medication for addiction treatment. I've been in the field over 30 years. I can tell you that new medications have made a dramatic impact on the likelihood of being able to successfully treat these patients and put them into indefinite remission. Buprenorphine is an outstanding drug. How many medications do you have in your armamentarium that can instantly reduce the likelihood of death by overdose by 50%? That's what buprenorphine does for individuals diagnosed with opiate use disorder. For individuals diagnosed with alcohol use disorder, oral naltrexone or injectable long-acting naltrexone, brand name Vivitrol, makes a dramatic improvement in reduction of cravings and returning to alcohol. So the injectable long-acting form of naltrexone, which is Vivitrol, can be used in individuals with alcohol use disorder, with opiate use disorder, or with both disorders in the same individual. Fourth is education on the disease of addiction. When we diagnose somebody with diabetes, we don't give them a bottle of insulin and a syringe and say, go on home and take it. We educate them about the disease of diabetes. We teach them how to check their blood sugar. We show them how their diet will have a significant impact in keeping their disease in remission. And we teach them about having their feet and their kidneys and their retinas checked on a regular basis, because these are all complications of their disease. Similarly, we teach our patients about the disease of addiction and what they have to do in order to remain in remission, hopefully for life. The next point is counseling and appropriate medication for co-occurring emotional and mental conditions. There is a significantly increased likelihood of a co-occurring diagnosis of depressive disorder, anxiety disorder, generalized anxiety disorder, bipolar disorder, and other mood disorders, and sometimes thought disorders in individuals diagnosed with a substance use disorder. We used to call this dual diagnosis. We now refer to it as a co-occurring condition. Next to last is a family and spouse and significant other education and therapy as needed. Very frequently, the families have been adversely impacted by an individual's recurrent heavy substance use. And finally, ongoing community support. There's nothing that works any better in the literature than support with 12-step groups such as Alcoholics Anonymous, Narcotics Anonymous, or caduceus groups, which are 12-step groups specifically for healthcare professionals, most often physicians. What is a relapse? A relapse is any return to mood-altering chemicals, but importantly, relapse and recovery rates are similar to those of other chronic diseases such as asthma, hypertension, chronic congestive heart failure, diabetes, cancer, and so forth. And most people can be recognized to be building up to relapse. So the more of these patients that you're aware of and get to know, then you'll be able to sometimes note when they're not saying things that really make sense, like, I dropped by my drug dealer's house the other day just to let him know I wouldn't be buying any more drugs from him. This is obviously a warning sign that they're thinking about using again. Relapse prevention includes proper treatment, sufficient continuing care and aftercare, developing community support through 12-step mutual support groups, and professional monitoring. Now let's talk more specifically about substance use disorders in healthcare professionals. We don't get help because of the same reasons that other people do. Number one is denial. I haven't had a DUI. I can't be an alcoholic. I don't use opioids every day, so I can't have an opiate use disorder, and so on and so forth. And we delude ourselves into thinking that we still have control over our chemical use. The fears of loss of employment, loss of licensure, loss of financial income, and loss of professional reputation oftentimes keep physicians and other licensees of the medical board and other boards from seeking help. It's just simply, I'm too scared to go get help because I've trained my whole life to be a doctor and I don't want to lose my job and lose my license. And very importantly, uncertainty as to how and where to seek help. That's one reason I'm here today. So when we did our well-being survey, the data from the 2021 OhioPHP COVID-19 well-being survey indicated that 56% of people noted that lack of time in order to get help for their substance use disorder or mental health condition, prevented them from seeking help. 40% didn't even know where to turn for support, and 31% noted confidentiality as the primary reason that they didn't get any help. So the question is, do you think that a licensed healthcare practitioner can obtain confidential assistance for a substance use disorder? The answer is yes, and this is the One Bite program that is allowed by the law that was passed in 2018. This allows individuals, again, doctors and other licensees of the medical board, to obtain clinically driven treatment, not necessarily 28 days of inpatient or residential treatment like it was before the One Bite rule, but clinically driven treatment for the duration and intensity that is clinically indicated by the diagnosing physician and treatment program. Number two, the ability to obtain comprehensive care at a One Bite program treatment provider. Right now, the medical board maintains the list of approved providers. We're kind of negotiating to turn that over to us, but I can guarantee you that all of the approved facilities are high quality programs and long-term support provided by the monitoring agency, which is us, the OhioPHP. So who is eligible for the One Bite program? A practitioner diagnosed with a substance use disorder who has not participated previously in the program unless the medical board referred the practitioner to the program themselves, which they still do. These are the licensees of the One Bite program. Ineligible are those individuals who are unwilling or unable to complete or comply with any part of the program, including evaluation, treatment, or monitoring, or the practitioner presents an imminent danger to the public, or the practitioner has relapsed, and then we must, by law, report them to the medical board. The requirements are a 72-hour diagnostic evaluation at appropriate facility for those with prescriptive authority, as well as anesthesiologist assistance. All other licensees, like massage therapists, can get an evaluation in 1 day at less cost at a medical board approved facility, who develops an individualized treatment plan 6-month minimum aftercare, which are weekly 1 to 1.5 hour follow-up sessions, and return to work by 2 individuals, the attending physician and myself at OhioPHP, before they're ready to go back to work, and monitoring with the OhioPHP, generally for 5 years. So are you, as a licensee of the medical board, under a duty to report impairment? The answer is yes. Licensees must report, quote, impairment of the ability to practice according to acceptable and prevailing standards of care because of habitual or excessive use or abuse of drugs, alcohol, or other substances. Now, what I would like to do quickly is add a slightly different presentation, if I may. And if you would kindly allow me to use this presentation that's being uploaded. And while that's being uploaded, the next slide is, what would you do if you were concerned that a colleague is suffering from a substance use disorder? Hopefully not any of these. And the correct answer is to call the Ohio Physicians Health Program. Okay, so how do we help? What I would like to do is again, if I could increase this to make to full screen. That what we do is explain the rules, if you will, that the medical board requires under the one-bite law. We get people into treatment at an approved facility, and then coordinate treatment and discharge planning with the primary treatment provider and clarify and explain to the treatment provider what Ohio one-bite law absolutely requires, so the individual is maintained and under the one-bite rule. This requires a 72-hour evaluation, 6 months aftercare, and coordination of ongoing treatment before individuals are allowed to go back into practice. Now, what is the alternative to monitoring with the Ohio Physician Health Program? People who choose or must go under action with the state medical board, the diagnosis and treatment become public information. Their disciplinary action is reported to the National Practitioner Data Bank. There's a period of license suspension, potentially fines, and monitoring by administrative and legal staff rather than our clinical staff. We believe that by providing confidential services to healthcare professionals, we can encourage individuals to seek treatment and get well and not get into trouble with the medical board. Now, do people actually get well and stay well? The answer is yes. Non-licensed healthcare professionals, non-licensed general population, in other words, what we call earth people without any letters after their name, have about a 50% sustained recovery rate after good quality treatment. However, healthcare professionals, usually physicians, most of the clinical studies have been done in physicians, 80 to 90% monitored for 5 years have no relapses. And the majority who relapse are a single relapse and they get right back into recovery. The good news is our study from 2004 to 2020, the OhioPHP, we have a 90% sustained recovery rate without relapse. I wish everybody that treated individuals with chronic illness could say that 90% of them get into recovery and stay in recovery. So we are required by law to keep everything confidential unless we have a specific written release from the practitioner. That might be to a residency director, it might be to the chief medical officer, it might be to a credentials committee, whoever the physician, PA, or other licensed healthcare professional wants us to communicate with, we can do that once we're given permission to do so. Even better news, all of our services beginning November 1st of last year are at no cost to the program participants, thanks to contributions for individuals such as yourself, as well as funding now coming from the legislature, as well as the Ohio Medical Quality Foundation, allowed us to eliminate all fees to participants, with the only exception being the cost of toxicology screens, which is billed by the lab itself. We are now providing services not just to the State Medical Board of Ohio, but the Chiropractic Board, Veterinary Board, Dental Board, and Vision Professionals Board, and we are expanding to all licensed healthcare professional boards in Ohio, including the Nursing Board, Counselors Board, Psychology Board, OTPT, and AT Board. By the end of next year, we should be providing safe haven programs to all licensed healthcare professionals in Ohio. So, there is a one-bite program. This is for licensees of the State Medical Board of Ohio. They're the only one that's called the one-bite program. That quality professional treatment and long-term support and monitoring has a very positive impact on outcomes. You do have a duty to report impairment. In other words, we can't just know that another physician or licensee of the medical board is impaired by mood-altering substance use. We must make a report. But very importantly, that duty to report is fulfilled by calling the OhioPHP. If the initial call is made accidentally to the medical board, then by law, the medical board must make that initial referral to the OhioPHP. And if the individual qualifies, then they're in the one-bite program. And we provide screening, assessment, and treatment referrals for primary or co-occurring mental health conditions as well. That's my formal presentation. There is another one that I was going to also include, if I can.
That's great. You have all these presentations out there. That's good. I like that. It's probably in there, hopefully.
It is. Go ahead and ask questions while I'm attempting to load this up now.
That's fine. That's fine. So I have one comment to start off with. I wanted to thank OhioPHP. I've been here in Salem for over 20 years now, and I'm a member of our medical staff. And I know through the years that OhioPHP has helped some of our medical staff members, and I know our hospital medical staff does donate to that, and I want to thank OhioPHP for their work. My first question is, so you do talk about the duty to report. Can providers or physicians, can they self-report? Can family members report? Who can call OhioPHP? Basically anybody, a colleague, family, themselves.
All of the above. Individuals can call us themselves. A family member can call. We get calls from residency directors. We get calls from fellow colleagues in a medical group. We get called from credentials committee or executive committees of hospitals, chief medical officers. What we really would like more of course, is self-report. But sometimes the denial is so strong that it gets very difficult for an individual to recognize that they have a severe disorder. So if they can report themselves, then we can take it from there. A spouse, family member, we will make the initial inquiries and do so confidentially.
I know those of you in the Youngstown area, there's going to be an event on October 11th at the Lake Club in Poland that OhioPHP and Dr. Christina Dolis-Reyes from the OhioPHP will be there to discuss some of this data. And so for people who are up my way, you can contact the Mahoning Valley Medical Society for that. My last question, Dr. Whitney, is you did mention the importance of counseling for the family and family members. Does Ohio PHP have that capacity? Or do they refer that out to other resources if family desire counseling?
We do not provide counseling ourselves. We provide a lot of information, and very importantly, we're starting a new process called behavioral health screens. And individuals can sign up for a behavioral health screen or be referred for a behavioral health screen, which will include a number of pre-screening questionnaires, the Malone Clinical Multi-Axial Inventory, depression and anxiety and substance use disorder screening tests, then an hour-long biopsychosocial interview with a master's level clinician, and then an hour-long, if needed, biopsychosocial interview with myself or one of our other associate medical directors, and then referred appropriately. We make an initial diagnosis, and we can either refer for treatment for a substance use disorder, primary mental health behavioral condition, burnout, or other conditions, and do so in a confidential manner. So even though we don't provide the counseling ourselves, we've got some really high quality individual group therapy, marital counseling, substance use disorder, and psychiatry treatment professionals around Ohio.
Great. I know if you were able to get your other slides in there or not.
It doesn't want to load. It said I can only order. Oh, wait a minute. Maybe I can trash that one. There we go. Let me go ahead and try it one more time.
Sure. Yeah. Well, this has been all very good information, and if we're able to get a little bit more information, I know I would be appreciative, and I know the audience would be appreciative too. So
it says it's processing, and I will do that just momentarily. With some data here that everybody in the Ohio Association of Family Practice would really appreciate. Very importantly, in our organization, I can tell you, I worked with the Ohio PHP, and no physician would ever complete treatment at Shepherd Hill without a referral to the Ohio PHP for monitoring. So I've known the individuals there. I've known Kelly Long, the executive director, for 16 years, Nelson Heiss, the clinical director, I've known for even longer than that, and it's a high quality group of very caring individuals. So some of what I would also like to throw in is the study that we did, which you can obtain from our website, the executive summary. And we were questioned, do reports of burnout and mental health symptoms and substance use differ prior to and during the COVID-19 pandemic? Of the almost 14,000 responses, 2,865, 21% of the total respondents were medical board licensees. A little over half of those were physician and resident physicians. 20% reported that they were furloughed or had forced time off or pay reduction, and 44% had a significant increase in their workload. Work stressors include concern about spreading COVID-19, inefficient communication from leadership, and 27% indicated that they were just too tired when they got home in order to pay attention to their families. During the pandemic, they accomplished worthwhile things left often, they reported. They felt emotionally drained. They cared less about what happened to some of their patients, felt down and depressed, thoughts of suicide, and concerns about their own alcohol and substance use. Okay? We had a 317% increase in reports of feeling emotionally drained from work every day, and a 619% increase in feeling down, depressed, hopeless nearly every day. So what we had, again, 1,559 fully licensed physicians, 54 residents responded prior to the pandemic. Prior to the pandemic, they were feeling down, depressed, and hopeless, having suicidal thoughts, and both prior and during the pandemic, emotionally drained, not caring about what happens to some patients, and accomplishing worthwhile things left off, and classic signs of burnout. Just 15%, however, ever accessed any kind of screening, assessment, or monitoring, and only 20% sought any emotional services for mental health concerns. Barriers being time commitment, confidentiality concerns, and fear of sanctioning by the regulatory board. So although we as physicians were already experiencing health and well-being challenges before the pandemic, it got a lot worse during and after the pandemic. But again, only 1 in 5 sought out support for emotional and mental health concerns. So, in order to prevent stigma, what we want and what we are encouraging actively are in negotiations is to assist the medical board to change their license application questions rather than questions, have you ever in your life or your career ever suffered from a substance use disorder or mental health disorder, to is there one ongoing presently that would impact your practice? These are also recommended by the Federation of State Medical Boards, so we're hoping that Ohio will bring these up to standards pretty soon. We are working with the medical board to review the processes and rules that might serve as a barrier for individuals to seek help for burnout, mental health, or substance use disorders. We use therapeutically driven methodology. We've got some great treatment programs in Ohio and outside of Ohio that we can refer to. And we are attempting and working with the medical board. This is what I talked to the medical board about last week. A medical board has a confidential track. We work with individuals in the One Bite program with a substance use disorder. We want to eliminate that barrier and have anyone able to come to us with any behavioral health, mental health, or substance use disorder condition. So our resources are as follows. This is the last 2 or 3 slides. The Ohio Physician Wellness Coalition. This is what we all love, free CME, right? OhioPhysicianWellness.org. We've got wellness video series, and we have topics including counseling, time management, boundaries, vulnerability, addiction, gratitude, and so forth. Watch these and get 11 hours of free CME and a lot of very useful education. The behavioral health screens that I alluded to, screening for burnout, mood disorders, depression, anxiety, concerns about substance use, or any other major psychiatric condition. The pre-screenings are mailed out by SurveyMonkey, taking confidentiality. Then there's a 1 hour or more, if needed, master's level counseling session, getting a complete biopsychosocial interview, followed by interview with myself or my new associate medical director, Dr. Christine Dellis Reyes. So we screen for burnout, stress, anxiety, any other mental health concern or substance use concern, and do so at no charge, except for the cost of the toxicology screen, which is about $60, and provide confidential feedback. So the recommendations might include additional diagnostic evaluations, individual counseling, sometimes group counseling, sometimes marital therapy, advice for medications. We refer this out to a clearly vetted, well-vetted group of individuals, psychiatrists, psychologists, counselors, therapists, treatment facilities, and so forth. Now, very importantly, this is another website. Please jot this down, wellbeingcare.org. We are the second PHP in the country to do this after Tennessee, and we are the individual that is on the back end of the back office of this. We work with the funding for the American Foundation for Suicide Prevention and OSMA for a customized prevention interactive screening program at no charge, confidential. Individuals who log on have the option to take a brief stress and depression questionnaire, receive a personalized or de-identified feedback from a master's level counselor at OhioPHP. The individual taking the survey has the option to identify themselves or not, as they so choose, and get referrals for additional information. They are ranked as far as 1A and 1B on level of suicidal ideation and planning, major depression, and so forth. But this can be completely de-identified with a software made up email address that will come right back to the individual's email address, or they have the option to identify themselves and get referrals for individual counseling. Wellbeingcare.org. So that was a lot of information to digest, and I hope individuals will please make note. That's the most important website, is wellbeingcare.org. If you're not sure where to go to ophp.org. All of this information is listed on our website.
I'm glad that set was able to be uploaded there. Great information. Just one follow-up question, Dr. Whitney. You touched a little bit about issues of physician suicide. Is there any kind of reliable data out there, especially for Ohioans, as far as physician suicide and numbers and things?
Yes, we had a significant increase in the number of physicians who were considering suicide during the pandemic and after the pandemic. About 4% acknowledged that they had seriously considered suicide during this questionnaire, the COVID-19 survey. And we had 22% of individuals who acknowledged that their substance use had increased markedly or increased moderately on our survey results.
Wow, wow.
Yeah, very
Uh,
significant. Very significant.
yes, yes, definitely need more study there. Well, thank you so much for all this great information, Dr. Whitney. I mean, you covered a lot of information, very valuable. Do you have any closing thoughts for our audience on anything that you talked about this evening?
The closing thoughts, one of the unfortunate things that we found was that most physicians and other licensees of the medical board don't know where to turn for help. And I can tell you that the Ohio PHP is a good first place to check, whether it's behavioral health, burnout, stress, suicidal ideation, substance use. Call us. We will handle it confidentially. If we get a subpoena for records, it goes right in the garbage. No information is ever released from Ohio PHP without a written judge's court order, and that hasn't happened in a long time. So if you're not sure who else to call, please call the Ohio PHP, and we will get you to the right individual, ophp.org.
And you just reemphasizing that this is if they're in the one by program, this is definitely a confidential process. So physicians, providers can be assured of that this will, like you said, won't be subpoenaed or revealed in any way.
Absolutely. And 42 CFR Part 2 is the federal regulation that governs us. And this is HIPAA on steroids. So we have absolute guaranteed confidentiality for all of our licensees, anybody who we get involved with.
Great, great. Well, Dr. Richard Whitney, thank you so much for being with us tonight. You have the website there. You have all the links there. If you're watching this on the replay, look at the comments. We have all the links that Dr. Whitney mentioned in his presentation in the comments below. Thank you so much for being here and great information. So thank you so much.
Thank you for having me, Dr. Sevilla. I really appreciate it. And everybody.
So that ends Bite-Sized Learning. And I challenge you, if you're watching this and you think it's valuable, I would share this with a colleague or share this with somebody that you would find it valuable. So that ends our program tonight. You can see any of our archives at ohioafp.org. So good night, everybody.